We will have the dedicated lecture. Dr. Wiggins will take us up and downstream through the cranial nerve to demonstrate the importance of the peri-neural spread. Dr. Wiggins is Associate Dean of the University of Utah School of Medicine and the Professor of Radiology and Imaging Science at the University of Utah Health Science Center at Salt Lake City, Utah, USA. Dr. Wiggins, the mic is yours.
Thank you, sir. Okay, so now we're going to talk in more detail specifically about peri-neural tumor spread. I have nothing significant to disclose, and we're going to talk about what peri-neural tumor spread is, how do we see it, and where do we normally want to look for it. And the idea is this. I'm going to break it up very simplistically. What is peri-neural tumor spread? How do you see it, and why should you care? We're going to finish up hopefully convincing that you should care about peri-neural tumor spread. So peri-neural tumor spread is neoplastic extension between the nerve and the nerve sheath. Peri-neural invasion is neoplastic invasion of a nerve. To me, peri-neural tumor spread, that's an imaging thing, and P&I is a pathology thing. You see these two confused, though, a lot in the literature, but you want to be sure you understand those are separate things. Peri-neural tumor spread is my job. Peri-neural invasion is the pathologist's job. So we're talking about different things. Peri-neural invasion is tumor between any of those three layers of the cell, epineurium, perineurium, or endoneurium around those levels, or tumor involving at least a third away of the outside of the nerve. That's peri-neural invasion. That's different than peri-neural tumor spread. But a lot of people use these interchangeably or get them wrong in the literature. Peri-neural tumor spread is neoplastic extension between the nerve, and that can be proximal or distal. It can be antegrade or retrograde. So that's very important when we look at nerves and try to evaluate it. A majority of head and neck cancer, everything that we talk about, is squamous cell carcinoma. 90 to 95% of all head and neck cancer is going to be squam. And somewhere it's a big range between 2 and 30% of those cases may have peri-neural tumor spread. But that's very different, as you've heard in these talks. Are we talking about squam of the upper digestive tract, or are we talking about squam of the skin? If you're talking about squam of the upper digestive tract, we're focusing more on nodes than peri-neural tumor spread. But if you're talking about squamous cell carcinoma of the skin, then we're focusing on peri-neural tumor spread more than lymph nodes. So we want to think about that when we look at the case. Every single time somebody says to you, head and neck cancer, we want to talk about where the lesion is centered, how big is it, where does it go. We want to look for lymph nodes, and we want to look for peri-neural tumor spread. Because peri-neural tumor spread is one of those things where if you do not look for it, you are not going to see it. It's very difficult to evaluate. We have to know about all these little nerves and where they go. Now, adenoid cystic as a pathology really likes peri-neural tumor spread. So adenoid cystic is only about 2% of all head and neck cancers, but somewhere between 30 and 95% of those cases may have peri-neural invasion, and about half will have peri-neural tumor spread. So adenoid cystic, if somebody says adenoid cystic cancer, really think about peri-neural tumor spread. Wherever that tumor is centered, think about which nerve that may be extending along and look very closely at that evaluation. Now, we're going to see much more peri-neural tumor spread with squames, just because we see way more squames than we do adenoid cystic carcinoma, but it's something we want to think about. And cutaneous squames are much more likely to have peri-neural tumor spread and peri-neural invasion. So again, if there's a squam of the upper digestive tract, we're going to think about nodes much more than peri-neural tumor spread. But if the squamous cell carcinoma of the skin, we're going to think about peri-neural tumor spread much more than lymph nodes on those cases. But we want to think about all three of those things in our report. Even if you don't do a radiologic T-N-M stage on every study, you want to at least say those three things every time somebody says to you head and neck cancer. Where is it centered? Where does it go? How big is it? Does it cross midline? Look for lymph nodes and look for peri-neural tumor spread. We want to be sure we think about those three things with every head and neck cancer case. So if we think about all the malignancies that happen in the salivary gland, adenoid cystic, maybe about 50% of those cases will have peri-neural tumor spread, and squames are much less. So we have some idea about how much peri-neural tumor spread should show up with all of these pathologies, but obviously that's just numbers. Your particular case is not important, just statistics. You're trying to look for it on every case all the time. You need to look for it because they're not going to have clinical symptoms that make it obvious to the referring doc. Less than half of the patients with peri-neural tumor spread have symptoms from the peri-neural tumor spread. the primary tumor is going to be much more exciting in terms of their clinical presentation. So we can't rely on the clinical presentation or clinical evaluation to think about perineural tumor spread. And perineural tumor spread risk is higher with poor differentiation, the bigger the tumor, or if it's recurrence, like post-therapy. They've already had chemo, radiation, whatever, and they come back and they have a recurrence at that area, they're more likely to get that. There are some things that we talk about that are important that are not in the AJCC criteria. Perineural tumor spread is one of those. We know that the patient does worse with the worst differentiation. If you hear your pathologist talk about, well, this is a well-differentiated, a moderately or poorly differentiated cancer, that's not in the AJCC criteria. And perineural tumor spread is not in the AJCC criteria. Angioinvasion is not in the AJCC, but those are very important in terms of how we treat those patients and their long-term outcome. So why does it happen? There's a lot of literature, and it's kind of all over the place about why we see perineural tumor spread. So people have talked about the path of least resistance, trying to look at actual physics of the nerve and the anatomy. People have talked about the epineural lymphatics and where they are, just like people get excited now, the brain guys talk about glymphatics around the brain and where they are. And if you look at the literature, people have looked at a whole bunch of factors. Neurotropic factors, nerve growth factor, these cytokines they get all excited about, chemokines, substance P, it sounds very exciting. So there are all these different things that have been in the literature, but a lot of these guys very clearly on their paper are convinced that the one they talk about is the definite one that's causing perineural. So you're a little suspicious of all of those. So how do we see it? So we're going to see it best with contrasted MR. That's going to be better than CT. That's going to be PET. That's going to be better than PET. That's going to be better than the ultrasound. I do have some cases where I have technically seen perineural tumor spread on ultrasound, and you can sometimes see it on PET, a little line going over. When we do PET CTs of the soft tissue neck, I do a dedicated soft tissue neck protocol. I give those patients contrast, and I do thin sections, 3 millimeters, whatever you do for soft tissue neck. The guys who do just one thick 1 centimeter tissue attenuation correction with non-contrast, you're not going to be able to see it on those studies. But MR is supposed to be very sensitive if you look for it. If you don't look for it, you're definitely not going to see it. And one of the important things when we think about these cases is fat is your friend. Not my friend necessarily. I have a sweet tooth, but maybe yours. The idea here is that the pre-contrasted T1 is sometimes more important than the post in the head and neck work, because where there is air and where there is fat is very important. So like we talked about earlier, if you're doing a soft tissue neck CT, it's very important you start with a window something like 440, so air is different than fat. Because where there's air and where there's fat is very important in a lot of pathologies. And when we think about the axial T1 before contrast, I don't want to do fat saturation on those cases. The nose knows, the nose is dark here, so this is before contrast. So I can see the retromaxillary fat pad, I see the pterygopalatine fossa, I see the normal fat that's around V3 under ovale. If I find my condylar head and go a centimeter medial and a centimeter anterior, that's where V3 is under ovale. That's how you can find that, where V3 is down low. So we want to pay close attention to those T1 before contrast, and we don't want to do fat saturation on those images. We don't want to do this. What do you think about this image? It's making me angry. I'm having a visceral reaction towards this image. Don't do fat saturation on your pre-contrast T1. It's a huge waste of time. I want to see where there's air and where there's fat. That's how I tell where tumor is. If I do fat saturation, I can't see anything. You've totally limited that exam. Now, it's also very important to see it because sometimes your tumor is in an area where the stuff around the tumor is enhancing the same degree as a tumor is. It's hard here to see where the tumor is. But if I had looked at the T1 pre-contrast, there's obviously a big tumor in that parotid. That is much easier to see on the T1 before contrast than it is to see on the T1 after contrast. So you have to put the T1 pre and post right next to each other and compare them side by side. Some people compare them top to bottom, but there's something wrong with those people. Don't be that guy. Put them right next to each other and compare them side by side. And again, anytime we have an isolated cranial nerve deficit, we want to think about imaging from the origin nucleus all the way out through the end organ. For perineural tumor spread, we look for enlargement of those foramen, and have you lost the border around it, the cortex? Do we have a good white line around that foramen or a black line on CT, or have we lost that? And think about radiologic skip lesions. Sometimes there's tumor crawling along a nerve with enhancement, and then there's no enhancement, and then there's more enhancement later. But when they do surgery, it's tumor, tumor, tumor. So there's an arterial neural plexus around it, and sometimes it enhances. Sometimes there'll be little areas that don't enhance and then more enhancement later. That's a radiologic skip lesion. There's tumor all the way along the course, but we may not see it all enhancing on imaging. So where do we see it? So in my practice, I see it more in the trigeminal nerve than the facial, and I see it on V2 more than V3 than V1 more than the facial nerve in the cases that I had that I reviewed in a retrospective review recently. So anatomy, we already talked about this, but we think about mostly the trigeminal nerve and the facial nerve. So we have the trigeminal nerve with Dr. Schroff's trigeminal nerve gang sign that he says all the time, and we have the facial nerve that we think about with his pes anserinus as it goes through. We think about perineural tumor spread mostly on those two nerves. And with the facial nerve, we're trying to distinguish, is that normal enhancement or is the canal actually enlarged to help differentiate perineural tumor spread from normal enhancement? So when we see cases on pathology, if you've got a big skin squame on your, near your eyelid, we think about where it is. So wherever the tumor is, we're going to think about what nerve is going near that area. If it's near your eyebrow, we're going to think about V1 and that foramen right there. And we see here nicely perineural tumor spread going back along V1 at that level. And we look very closely at the muscle. So we think about where that superior rectus is and the little levator palpebrae. If there's an extra little bump above it, we're going to remember that at that level, perineural tumor spread going back. If we have a lesion at the cheek, we're going to think about going back posteriorly. That infraorbital canal, people sometimes draw it parallel to the optic nerve, but it's not parallel. It's straight in the sagittal plane. So it goes straight back along V2. It skirts the lateral aspect of the pterygopalatine fossa at the pterygomaxillary fissure, and then it may get on rotundum and go back from there. As you can imagine, it's hard to palpate back there, and we may not see those clinical symptoms. So it's our job to try to tell them if the tumor's back there. So I look for loss of fat at the pterygopalatine fossa, where the pterygopalatine ganglion is, but we have all this soft tissue that's going back, and on MR we see better how it's going back in the rotundum canal. People call it a foramen, but it's obviously a tube. It's a canal. Now, if the clinical information is huge, just like everything else in the head and neck world, if I get this study and it says rule out abnormality, I might miss this. But if they say, hey, I think he's got a tumor on his cheek, we want to look at it, I can see that's the primary tumor, and that's the perineural tumor spread back there. And I can see it on the T1 pre without contrast. I don't need any other sequences because I know where there's supposed to be air and where there's supposed to be fat. I can look at that and tell exactly where the tumor is. So if it's on V2 and it's going back into the rotundum canal, as you saw earlier, we see a lot of enhancement there at that level, and we can follow it back along rotundum in that canal all the way back to the trigeminal cistern or Meckel's cave, if you like to name stuff after people. If it's along V3, we saw some cases earlier going down V3 through a valley at that level, enlargement of the nerve with abnormal enhancement going up in that case. Now, there is a little nerve called the auriculotemporal nerve that connects kind of 5 and 7 behind the mandible. And this is a case of adenoid cystic that is actually crossing over from the facial nerve in the parotid over to V3 under ovale. So there's an auriculotemporal nerve that may cross over at that level. Now, this is a case we looked at earlier where we saw the tumor. It's a lot easier to see on the T1 pre. But sometimes everybody's focused on the tumor, especially the brain guys. If they don't do head and neck and they're not familiar with it, you really have to think about it. If you don't think about it, you're not going to see it. They had this case and they were following up the primary tumor over and over again. So they were looking at the tumor at this location and they were following it up over time. You see how small the pituitary looks, nice and thin, top to bottom? So they're following it up. This guy had perineural tumor spread, but everybody's focused on the primary tumor. Nobody's looking for perineural tumor spread. The tumor was going up, it got into the trigeminal cistern. Look how big the pituitary is. Do you know why that is? The cavernous sinuses connect under the pituitary. The tumor got in the cavernous sinus and was crawling under the pituitary to get over to the other side. It's pushing the pituitary gland up. It's going over to the other side, and then it starts going down on the other side, down through V3. This was all missed because you weren't looking for it, probably. This was missed on every single one of these cases. He had obvious perineural tumor spread. And later, there was big obvious tumor in both cavernous sinuses and trigeminal cisterns. But if you don't look for it, you're definitely not going to see it. So we have to think about that cancer that may be going up. Can go retrograde or antegrade, can go proximal or distal along these nerves. Anytime the facial nerve is avidly enhancing, we have to look at the parotid to see if there's a big tumor in there. So we want to be very careful about that. If I think there's too much enhancement along the facial nerve, I'm going to look at the parotid to be sure there's not a tumor there. And we want to differentiate that. If I just see a little tuft, I might think about a herpetic or Bell's palsy, but this guy who they thought was a Bell's palsy, he had a tumor in his parotid, but nobody thought to go look for it because they weren't thinking about perineural tumor spread. So to finish up, why should you care? There is an increased risk of tumor recurrence with perineural tumor spread. Again, there is stuff that we sometimes talk about at our tumor boards that's not included in the AJCC criteria. The tumor differentiation is important. Perineural tumor spread is important. Things like angioinvasion is important, but it's not in the TNM stage. They always want to focus on the tumor and the nodes and metastatic disease. And we have a higher morbidity and mortality if there's perineural tumor spread. Your outcome is going to be worse. And I argue that perineural tumor spread significantly changes management. And from what we hear, it's not going to be in the AJCC9 either. If you have tumor that's going all the way back along the trigeminal nerve, and it's going all the way back along the cisternal segment of the nerve, and it is touching the pons, you're not going to change that guy's outcome by doing a big facectomy. And it's hard to palpate the pons. Who knew? So it's my job to tell them that the tumor is back there. This guy has a very different outcome. He's not going to have a big surgery because we saw there was perineural tumor spread going all the way back and into the pons. So think about the anatomy, whichever cranial nerve is that you're thinking about. Pay attention to where there's fat and air on these studies, and don't ignore the pre-contrasted T1. And don't do fat saturation on the pre-contrasted T1. So that's a review of perineural tumor spread. What is it? How do you see it? And why should you care? Hopefully now you care. And I thank you very much for your attention.